25 questions. We're going to give you about 15 seconds to note down your answers. Okay, so let's get started. A special thanks to Dr. Kaushal Pokharel. He is one of the incoming refractive surgery fellows at Tilganga Institute of Ophthalmology in Nepal, and it is thanks to him that these questions have been contributed. Question number 1. Lasers in keratorefractive procedures involve which of the following principles? A, photoablation. B, photothermal. C, photodisruption. Or D, all of the above. Question number 2. Which of the following is not an aberration? Is it A, myopia? B, presbyopia? C, simple astigmatism? Or D, hypermetropia? Question number 3. What is form first keratoconus? Is it A, keratoconus without slit lamp findings? B, an eye with normal clinical and topographic findings with the other eye diagnosed as keratoconus? C, ectasia, keratoconus, following LASIK surgery? Or D, a normal eye, but with tomographic findings resembling keratoconus? Question number 4. For ablation of corneal tissue in refractive surgery, which laser is used? Is it A, femtosecond laser, B, excimer laser, C, UVA laser, or D, all of the above? Question number 5. Which of the following does not involve tissue ablation? Is it A, LASIK, B, epi-LASIK, C, PRK, or photorefractive keratectomy, or D, SMILE, which stands for small incision lenticule extraction? Question number 7. Pentacam data includes all of the following except A, keratometric values, B, corneal thickness values, C, back and front elevation values, or D, corneal epithelial thickness values. Question number 8. Laser vision correction is not indicated if the patient A, is above 40 years of age, B, is above 18 years of age, C, has high expectations, D, has a previous history of laser vision correction. Question number 9. Photorefractive keratectomy can be done in A, corneas thinner than 470 microns, B, patients with epithelial basement membrane dystrophy, C, subclinical keratoconus, or D, connective tissue disorders. Question number 10. Tomography is not based on A, Placido disc-based system, B, Scheimpflug-based system, C, OCT-based system, or D, none of these are tomographers. Question number 11. Indications of LASIK include A, myopia up to -14 diopters, B, hyperopia up to +5 diopters, C, astigmatism up to 5 diopters, or D, all of the above. Question number 12. The greatest amount of biomechanical weakening is seen in A, PRK, B, SMILE, C, LASIK, or D, collagen cross-linking. Question number 13. The surgery of choice in athletes who have higher chances of ocular trauma with a refraction of -4.0 sphere, -0.25 cylinder at axis 90 degrees is A, PRK, B, LASIK, C, SMILE, or D, any of the above? Question number 14. The common causes of ectasia and its progression include A, connective tissue diseases, B, eye rubbing, C, laser vision surgery, or D, all of the above. Question number 15. Residual stromal thickness in LASIK surgery is calculated as a difference of total corneal thickness from all of the following except, is it A, ablation depth, B, flap thickness, C, pre-decimase thickness, or D, all of the above? Question number 16. Which of the following is not part of refractive surgery? A, radial keratotomy. B, multifocal lens implant following lens extraction. C, implantable Collamer lens, or D, contact lens. Question number 17. A 25-year-old student with -18 diopter glasses is interested in refractive surgery. What would be an appropriate choice for her? Would it be A, PRK LASIK if corneal thickness is adequate? B, a refractive lens exchange with monofocal posterior chamber IOL? C, implantable Collamer lens? Or D, SMILE? Question number 18. Which is not true about spherical aberration? Not true. A, it increases the depth of focus and thus patients can see near better. B, it is the reason of glare and halos, especially at night. C, it decreases the contrast. Or D, all of the above are true. Question number 19. Higher order aberrations include all of the following except A, coma, B, against the rule astigmatism, C, spherical aberration, or D, trefoil. Question number 20. The test to find out the dominant eye is needed in A, myopic LASIK, B, hyperopic LASIK, C, presbyopia correction, monovision, blended vision, or D, bilateral multifocal lens implant. 21. Who is not a good candidate for multifocal lens implants following cataract surgery? Would it be A, a driver with the need for nighttime driving, B, a banker with lots of screen time, C, a housewife or homemaker, or D, a motivated man with posterior subcapsular cortical cataract? I want to introduce my dear friend, Dr. Drew Dickson. The two of us had done physician CEO together at the Northwestern Business School, and we graduated in September of this past year. Just to give you a overview of his background, he is from Clear Lake, Iowa. He did his undergraduate university at Liberty University, his medical school training at the University of Nebraska, and he was even able to spend a month during that time in Kumasi, for those of you who are on the call from Kumasi. He did his residency at the Storm Eye Institute at the Medical University of South Carolina, and his fellowship through the Refractive Surgery Alliance at Kugler Vision in Omaha, Nebraska. And you can see behind him is the sign for Kugler Vision. It is my dear honor and pleasure to introduce Dr. Drew Dickson. Dr. Dickson, handing it over to you.
All right. Well, good morning or good evening to all of you, wherever you are. It's morning over here in Omaha. It's my pleasure to be here. Thank you so much, Ashiyana, for this initiative. You are all very fortunate to have someone like Ashiyana looking out for your best educational interests, and I'm excited to help be a part of this program and collaborate with her again. So most of you, it's my understanding, do not have much exposure to refractive surgery, which same for United States residents. There's very little exposure to refractive surgery as residents. It is a tall task to get through an entire textbook in just a few minutes, but we'll try to go over some of the highlights and really want to focus on some of the concepts of refractive surgery with you all. I have intentionally made the slides to have more content probably than what we will get through in any level of detail, but they're there as a reference for you as you're looking back and studying. So our agenda today will first kind of talk about what is refractive surgery and why perform or go into refractive surgery, and then go through each of the subsequent book chapters and talk through some of the highlights from each of those chapters. So refractive surgery is surgery that's intended to fix people's focus and increase their independence from needing glasses or contact lenses to fix their vision. There are many types of refractive surgery. We kind of think of them in two big groups, either cornea-based refractive procedures or lens-based. I understand that you guys all just completed your sessions on cornea, so some of those concepts will transfer over to what we talk about when we're talking about some of the corneal-based refractive surgery options here. But just wanted to touch briefly on why do refractive surgery. To many, it seems like it's an expensive luxury, and it's really much more than that. So we know that there are safety benefits, there are functional benefits, there are financial benefits from refractive surgery. Through various studies, we know that patients have higher satisfaction with refractive surgery compared to being in contact lenses or glasses long-term. You significantly lower risk of microbial keratitis compared to being in contact lenses. There have been recent studies that actually show that those elderly patients who need bifocals for presbyopia correction actually have a higher fall risk. And at least in the United States, 1/3 of all falls are attributable to issues with bifocals and having that image jump and image displacement from the bifocals. LASIK itself is the best studied surgery in all of medicine. It's had the most number of procedures and the most studies performed. So it's not some new thing that is just we're flippantly fixing people's corneas. It's extremely well studied. And one thing that's very interesting is that out of any demographic group that has ever been surveyed on having had refractive surgery themselves, refractive surgeons are the most likely to have ever had any type of refractive surgery, which I think speaks to the safety and efficacy and our belief in what we're doing. So I've listed just some articles that kind of go into more detail over some of those concepts, just talking about satisfaction, risk for infections, and the falls, and actually it's a recent article too on cataract surgery and dementia development. So many reasons to do refractive surgery. I myself have had LASIK and performed a lot of LASIK too. So, and I'm very happy with not needing to wear glasses or contacts anymore. So that all being said, let's dig into the book a little bit here. So this first book, or first chapter here, talks about the science of refractive surgery. So we'll go through some of the main concepts here. So as you guys know, especially from your study of the cornea, the majority of the refractive power of the eye occurs at the air-tear interface. So we think of the total corneal power of being about 42 diopters, about 48 diopters from the anterior surface, and then -6 diopters from the posterior surface. When we think about doing corneal refractive surgery, we're either going to steepen the cornea to increase the central power, or we're going to flatten the cornea to decrease the central power. So if we're doing a myopic correction and trying to fix somebody's nearsightedness, we're going to be flattening that cornea, which in turn makes the cornea become more oblate, which means that the periphery of the cornea is steeper than the central cornea, which we'll see here in a second. The opposite is true for hyperopic correction. So regardless of the procedure we're trying to do, if we're doing a hyperopic correction of the cornea, we're going to steepen that cornea centrally, and the cornea will become more prolate. So this image from your book shows an image A, the normal prolate cornea, where it's steeper centrally than in the periphery. B represents an oblate cornea, possibly after a myopic ablation, where you can see it's flattened more centrally than the periphery. And C represents a prolate, or what we'd call a hyperprolate cornea, after having some hyperopic correction to steepen that central cornea and increase the corneal power. So some of the concepts that they talked about in this book, one of the big ones for this chapter was talking about wavefront analysis and wavefront aberrometry, which I wasn't exposed to much as a resident, and I don't expect you guys to know much about it either. But it's a technology that's very useful for certain types of treatment planning and can explain visual symptoms of people related to what we call higher order aberrations that we'll talk about in a little bit here. So this is a diagram of one type of a wavefront aberrometer. Essentially, you have a point source that in this model shoots a laser into the eye and then has image reflected back, and the machine is able to detect how that laser is reflected back through the eye and determine what type of aberrations are coming from that eye. So when we talk about aberrations, these are typically explained in the form of Zernike polynomials, is the mathematic way to describe these. And you're given what's called a root mean square value. These values that were given, we typically consider normal if they're less than 0.3. And this is an example of those Zernike polynomials that we're talking about. So at the top of this pyramid are what we would consider the lower order aberrations. So you have your 0 order, which is piston, which is visually not relevant. First order, you have tilt or prism. Second order, you have defocus. So that can be positive defocus or negative defocus, which represent myopia and hyperopia. And you also have astigmatism. Those are all what we would consider lower order aberrations. Higher order aberrations are when we're getting into this third level, where you see trefoil and coma. And then in the fourth level, the biggest one that's probably the most visually significant is what's called spherical aberration. So spherical aberration arises from light being refracted differently at different points in the optical system of the eye. And so these light rays in positive spherical aberration are refracted more at the periphery of the cornea compared to the center of the cornea, and that causes some image blur and distortion. And that's typically for people who have normal vision during the day, but struggle with nighttime glare and halos and things. Typically, spherical aberration is the cause, because at nighttime our pupils dilate and more light is hitting the edge of the lens inside the eye and causing this positive spherical aberration. So those are what we're talking about when we're talking about higher order aberrations and aberrations of the eye that this wavefront aberrometer can detect. Some other technology that's important in refractive surgery for imaging includes topography, which hopefully most of you are familiar with. There are different types of topography. The main one we typically think of when we're talking about topography is Placido disc-based imaging, and you guys may have had some discussion on this during your cornea lecture, but the Placido disc-based imaging essentially shows concentric rings of the cornea that relate to the steepness or flatness in a certain area. There are different ways to interpret these. There's axial scans, which are used more commonly in refractive surgery screening because they offer less noise and are better for central corneal imaging. And then there are also tangential scans from topography that are better for periphery, but tend to have more noise in the images and can sometimes be harder to interpret. But this is an absolute must for refractive surgery. When we're looking at these things, we're assessing for astigmatism, so looking to see if it's regular astigmatism or irregular astigmatism. The Placido-based topography is nice at showing us if the surface looks regular or not, which often can reflect a poor tear film if the Placido disc imaging is poor. And we're also looking at signs for ectasia. So looking for signs for keratoconus or pellucid marginal degeneration or those types of things that we would be worried about and would potentially rule out someone from being a refractive surgery candidate. So that's topography. We're just looking at the anterior curvature of the cornea. Tomography goes a step further, where we're actually able to get posterior corneal data. There are different types of tomography out there. There are scanning slit, there are Scheimpflug based, there are OCT based. technologies out there to get posterior cornea data, but it's best at expressing the overall corneal shape. And this posterior data is very useful in refractive surgery because often if someone has early keratoconus, or looks suspicious for keratoconus, you can see changes on the posterior surface and see posterior elevation centrally before you would see any signs of keratoconus on an anterior scan just from topography. So it can help us to rule in or out patients for refractive surgery earlier than just topography alone. Another very useful technology that we now perform on all of our refractive surgery candidates where I'm at now is something called epithelial mapping. So epithelial mapping was first described by Dan Reinstein 20 plus years ago using high frequency ultrasound to actually identify and map out the epithelial layer of the cornea. And nowadays, you can still use high frequency ultrasound to do that, but there's OCT based technology that's more practical in a clinic and for screening. But is the thing to know about the epithelium is that it's reactive tissue. So it will react to any stromal irregularities that you see in the cornea. So if you have areas of stromal thinning, you'll see thickening of the epithelium and vice versa. If you see thickening of the stroma or steepening of the stroma, you'll see reactive thinning of the epithelium. So this, again, is an excellent screening tool for refractive surgery. This is an example from the text of an epithelial map that we see in someone with keratoconus. So one of the classic things that you will see with keratoconus on epithelial mapping is thinning of the epithelium over the cone. And so you can see, I don't know if you can see my cursor here, see my mouse here or not, but right here, this blue area that you see represents thinning of the epithelium that would make it suspicious for keratoconus. Now, the converse is also true. I actually saw a patient this morning who on her pentacam had looked like inferior steepening on her pentacam image. And then looking at her epithelial map, I actually saw that her epithelium was thickened and was the cause for this appearance of inferior steepening on her pentacam. And a lot of times that's related to contact lens warpage or dryness. And so often if you get the surface treated, that epithelium will normalize and the entire pentacam will normalize. So before having epithelial mapping, seeing an image like that where you would see a lot of inferior steepening on a pentacam would most of the time rule out someone as a refractive surgery candidate. Now it can actually help to rule in or rule out patients. So it's a very useful piece of technology. Moving into the corneal biomechanics. So important things to know is that most of the integrity and the strength of the cornea comes in the anterior 1/3 of the stroma due to more branching and interweaving of those collagen fibrils and those corneal lamellae. After we do any cornea-based refractive procedures, the cornea is weakened, which can lead to what we would call post-refractive surgery, or the most common one you'd hear about is post-LASIK ectasia, where you can develop progressive thinning and steepening of the cornea with irregular astigmatism in a pattern that's very similar to keratoconus. So that's what we're always worried about in performing corneal-based refractive surgery is, do they have enough corneal tissue? Is their corneal tissue normal? Is it strong enough? We'll get into talking about that a little bit more, but it's important to know that the anterior 1/3 is usually the strongest, and that is the spot that we're actually operating on the most, typically with most of the surgeries we do. So even though can leave a adequate amount of tissue behind after our surgeries, doing surgery and removing some of that anterior 1/3 can disproportionately weaken the cornea. Corneal hysteresis is a term used to describe the biomechanical property of the cornea that reflects its ability to absorb and dissipate energy. And there's technology out there that's available to actually test that now. It's not routinely performed in most refractive surgery centers, but can be useful when assessing corneas for refractive surgery. This chapter touched a little bit on astigmatism, incisional techniques. We'll touch a little more on that in chapter 3 as well. But some important concepts to realize with any type of corneal incisions we do to address astigmatism is that all incisions cause local flattening of the cornea and the meridian that you're making the incision. For radial incisions, like were used in something called RK, these cause flattening in the meridian of the incision and flattening 90 degrees away. If we do a tangential incision, which I'll show you a picture of here in a little bit, these cause flattening in the meridian of the incision, but steepening 90 degrees away. And this is what's known as the coupling effect. And so this is why if you perform an arcuate keratotomy or something called a limbal relaxing incision, the spherical equivalent remains neutral. You're not inducing any steepening or flattening of the cornea if you do a peripheral tangential incision. Some of the things that will affect the potency of these incisions are smaller optical zones. So when RK was performed, having a smaller optical zone created more of an effect. So they'd create longer incisions going more central into the cornea. Tangential incisions the effect can be increased in a number of ways. Longer incisions will induce more of an effect within 3 clock hours. If the incisions are closer to the visual axis, they have more effect. Older age, greater depth, all will increase the potency of these incisions. These incisions, oftentimes now when they're combined with cataract surgery, are performed with a femtosecond laser at our practice, but we still perform lots of manual arcuate incisions as well. And they're used in a variety of things that we'll talk about in a little bit. But this is just a diagram showing some of these peripheral incisions. You have arcuate, tangential, or limbal relaxing. We'll talk a little bit more of that in chapter 3, but some of those concepts are important to understand before we get to that. Talking about laser biophysics, these are important concepts to understand as well. So there are 3 main types that the book discussed of types of lasers and their effects. So the first that we'll talk about is photoablation. So this is used in excimer lasers. Excimer stands for excited dimer. And basically what is done with these lasers is there's an electric impulse that stimulates argon and fluorine gas to form what we call these excited dimers. And that energy created from these can break bonds within the cornea, break chemical bonds, carbon-carbon and carbon-nitrogen bonds. The wavelength used by an excimer laser is 193 nanometers. That wavelength of light is very precise, has very low tissue penetrance, and is non-mutagenic. So when we talk about using this for ablations that we would do in PRK or LASIK, it's very precise. You're not affecting the other surrounding tissue that you're not intending to ablate. It's not a hot laser. It doesn't create thermal energy, and it's non-mutagenic, so it works very well in refractive surgery. So that's important to know. The 193 nanometer wavelength is a very testable thing too. So that's an important thing to know. The next type that we'll talk about is photodisruption. So photodisruption is used in femtosecond lasers, which a femtosecond stands for 1/1,000,000 of 1/1000,000 of a second. So this is a very fast laser, very quick. This laser is used in LASIK SMILE and can be used in refractive cataract surgery as well. The wavelength used in photodisruption is 1053. So that's important to tuck away as well. With photodisruption, tissue is turned into plasma. This plasma is then creates high pressure and temperature that will cause tissue expansion to form cavitation bubbles. And we can use those cavitation bubbles to create planes within the cornea that we use to create corneal flaps in the case of LASIK, or we can create lenticules in the case of SMILE. You can also use femtosecond laser in cataract surgery to create arcuate incisions like we talked about. You can create a capsulorhexis with them. You can use femtosecond laser to help in your breakup of the lens itself to make your cataract surgery more simple and have to use less phaco energy if you're using phaco. And so there are a lot of uses for femtosecond lasers in ophthalmology and especially in refractive surgery. The last type of energy, laser energy that this chapter discussed was photothermal effects. So this is achieved with a holmium YAG laser. Essentially using this laser to change the shape of the cornea creates heat energy. So it's a thermal effect and causes collagen shrinkage with steepening of the cornea. So it used to be used in the periphery of the cornea, not commonly used anymore due to regression effect. I've never seen anyone who's had this done. I've never performed it myself, but something just conceptually to know about is the photothermal effect of the holmium YAG laser. So other fundamentals from this chapter, talking about myopic treatment pattern. We talked a little bit about this. This is just an example from one of our lasers that we use. The center, the purple here represents where the ablation, most of the ablations are being performed. So this in a myopic ablation pattern, we're flattening the central cornea to create less corneal power to take away patients' myopia. And that's the treatment pattern with LASIK and PRK for a myopic patient. With hyperopia, instead of treating the center, we're treating the periphery of the cornea, and that peripheral removal of corneal tissue induces central steepening in the cornea to treat hyperopia, to give the cornea more effective power and correct farsightedness for patients. So that kind of understanding the basic ablation patterns is important. Another thing that is easily testable is something called the Munnerlin formula. So this formula allows us to estimate how much tissue is removed centrally in a myopic ablation, which is important because there are limits to how much tissue we can safely remove from the cornea without increasing risk for post-refractive ectasia. And so the Munnerlin formula, you can estimate the ablation depth by taking the degree of myopia you're treating times the optical zone diameter. So the optical zone is the area of the ablation that is treating the prescription. Most commonly nowadays, the optical zone is greater than 6 millimeters. We, as a standard, typically for myopic treatment, we'll use 6.5 millimeters as our optical zone. But you can see that by decreasing the optical zone, it has an exponential effect on the amount of tissue that you're removing. So that can be a way, if you have a high treatment and are trying to preserve more cornea, you can decrease the optical zone to remove less tissue. And so that's an important formula to tuck away and understand the basic principles of that, is that you're going to remove more tissue the greater the optical zone and the higher the degree of myopia that you're treating. So that's called the Munnerlin formula. Some other things related to treatments that are important are being able to estimate post-op Ks. Historically, this was thought to be more important than some of the current literature, but still important to know. And so with a myopic treatment, you can estimate the amount of flattening by taking the amount of treatment you're performing times 0.8, and that will be the effective flattening. So if you're doing a treatment of 5 diopters, you can take that 5 times 0.8 and you'll get close to 4 diopters of flattening. With hyperopic treatments, to estimate the post-op Ks, you just take the treatment diopters times 1. So if you're going to do a hyperopic treatment for 2 diopters, you can estimate that you'll have about 2 diopters of steepening. So those are important to know as well. Talking about excimer lasers, there are different types. Historically, the first model was called a broad beam laser. This had a large beam that had slow rates, but had some issues with it. And that caused for some of these newer lasers called scanning slit and flying spot to be evolved. Most modern lasers today use flying spot technology, where instead of being a big broad beam doing the entire treatment, there will be many smaller spots doing ablations, which is more precise and causes less complications than the broad beam technology used initially. So one last slide on this and we'll move on to the next chapter. So talking about different types of photoablation, there are multiple different types out there. These are always topics of debate at a lot of the refractive surgery meetings on which is best and which is more superior. And there are people who will pontificate and discuss this probably till the end of time. But just important to have a basic understanding of these. So conventional laser, what was initially used small blend zones. Blend zones, unlike optical zones, don't do anything related to the prescription. The optical zone is in a myopic ablation is the central treatment zone, and blend zone reflects the areas outside of the optical zone that you're treating. And there really weren't much for blend zones early on with conventional lasers. And because of that, more higher order aberrations were induced. So with myopic LASIK, you would get more positive spherical aberration related to that. Because of these orders of higher order aberrations, other technologies were developed. The first was called wavefront optimized. This utilizes data from normal cornea profiles to create generic blend zones based on 99+% of cornea profiles to decrease HOA formation and have larger blend zones that decreases the amount of spherical aberration induced. There's also wavefront guided, which actually uses the wavefront aberrometer that we talked about earlier and measures patients' individual wavefronts to then calculate a treatment to do to try to eliminate some of those higher order aberrations. And then the final type that we'll talk about is topography guided, which actually uses repeated topography measurements from patients and in conjunction with the patient's prescription to treat the cornea to try to eliminate some higher order aberrations and create a smooth corneal profile. So that's it for the science. That was one of the longer chapters we'll go through, but I think there were a lot of really important concepts to discuss there that are very testable and important to know. Chapter 2, in my opinion, is probably the most important chapter out of all of this. If anything you guys get from this is make sure if you're performing refractive surgery on a patient that they're a good candidate for it, because you can be the best surgeon in the world, but if you're doing surgery on someone who shouldn't be having surgery in the first place, you're causing a lot more harm than good. So patient evaluation is critical. I think this table from your text did a really good job of giving a summary on some of the basic things that are important to perform when doing a preoperative evaluation. So that's there for a reference, and you have that in your book. And we'll talk about a few of these here going forward. But the first thing to really figure out when a patient comes in wanting refractive surgery is what are their expectations? Do they think they're going to have perfect vision? You know, if it's a patient who is now presbyopic, do they expect to see like they were when they were 20 years old? What are they hoping to accomplish? What are their goals? What do they want to get out of this? If they expect a 100% guarantee that everything is going to be perfect, you shouldn't be performing surgery on them, because even though the technology is very good and very precise, it's not perfect, and we can't guarantee that to people. So you really want to make sure that they understand that even though they have a very, very high chance for success and to be happy after this, that there's no guarantees. Ocular history is important. So you want to make sure that patient's refraction is stable, which typically we quantify as being a less than a half diopter change over a past year. So if you can measure what they're currently wearing in their glasses or have them bring in an old prescription to compare what you're measuring, that's very useful. You want to find out about contact lens use, if they've developed contact lens intolerance, if they have scarring from prior infections related to contacts, if they've ever done anything like blended vision or monovision, if they're presbyopic, that's very important. And also knowing if they've had any prior refractive surgery. So that obviously would influence treatment planning and things. Medical history is important. Well, there's a chapter where we talk a little bit more about different medical problems with refractive surgery, but finding out if they have history of autoimmune disease and if that's active or stable, if they have diabetes that's well controlled or poorly controlled, if they're pregnant or breastfeeding is typically not advised to perform any type of refractive surgery because hormonal changes can actually induce some myopia. And so you want to make sure that the refraction is stable. Isoretinoin use or Accutane use is something that's important too, because that can impact wound healing and dryness. So all those things are very important. Examination, you want to check near and far vision. You want to check their vision corrected and uncorrected. You always want to perform a careful manifest refraction. In some patients, it's indicated to do a cycloplegic refraction. Some practices will do a cycloplegic refraction in all patients who come in looking for refractive surgery. Our practice, we typically just do it if they are hyperopic or if they have mixed astigmatism. But sometimes even for our myopes, we'll choose to do that. Ocular dominance is important, especially if you're thinking about doing blended vision or monovision. You want to know what the dominant eye is. IOP is important, pupil size, obviously, important to check and make sure there's no pupil irregularities. People who have larger pupils tend to have, especially the early thinking was that they tend to have more issues with glare, halos, those types of things. Some of the more recent data doesn't always lend that to being true, but anecdotally, patients who have large pupils, I actually saw a patient recently who's on Ritalin and some other ADHD medications that are, she's post ICL and she's having a lot of issues with glare, but her pupil size, even in a light room is like 7 millimeters. So she's having a lot of issues with glare that are not typical related to pupil size. So that's something to look at in your pre-op exam. You want to check motility and ocular alignment, and then do a careful slit lamp exam. So especially paying attention to dryness, any corneal or conjunctival irregularities that might affect your treatments are really important to look at. When we're doing other ancillary testing, I would say for essentials for any type of refractive surgeries, you need to have topography and tomography, especially if that's available, at least topography to be able to evaluate for astigmatism and screen for keratoconus. Pachymetry is a must because you need to know what their preoperative corneal thickness is if you're going to do a laser-based procedure to make sure you're not ablating too much tissue. And then if you're performing cataract surgery or what we would call a refractive lens exchange, biometry. And so some of these other beneficial things that we routinely get on patients are epithelial mapping, wavefront analysis, dry eye testing, getting an OCT of their macula to make sure there's no pathology there. Specular microscopy can be very useful, especially when we'll talk later about doing phakic IOLs or cataract surgery. And then most patients should have a dilated exam or at least wide field retinal imaging. If for all patients, if they're having any lens-based procedure, we do a dilated exam on them. If they're having LASIK or PRK or subsurface procedure, then we'll often do wide field retinal imaging instead. But those are some of the essentials. Again, really need to take into account patients' age, their expectations, their refractive error, if they have any signs of corneal irregularities. We'll talk a little more about residual stromal bed and percentage tissue altered if undergoing LVC, and then noting their anterior chamber depth and endothelial cell count if they're having an ICL. So percentage tissue altered is a useful way of thinking about if you have enough tissue left over after performing LASIK or PRK. So with percentage tissue altered, you take, in the case of LASIK, you would take your flap thickness plus your ablation depth that you can estimate using Munnerlin's formula, divided by the total corneal thickness. So most surgeons will have pause or be hesitant to perform laser vision correction surgery if that percentage of tissue that you're altering is greater than 40%. There's some evidence out there in some studies that talk more about the percentage of tissue volume that you're altering instead of just the depth being more significant, but it's helpful just to think about that and make sure you're not altering too much corneal tissue. This is just a scan of kind of how we think about doing treatments here at Kugler Vision. I won't go into depth there, but this is kind of a complicated chart, but it is a nice way of tying in age to their refractive error and typically what patients are candidates for and what we would recommend to them for refractive surgery. This is just a nice list of some contraindications. Some of these are more absolute, some are more relative contraindications, but things to certainly be screening for and looking for when you're evaluating someone for refractive surgery. So we'll keep moving along here. We've got a lot to cover. So chapter 3, incisional corneal surgery. We talked about some of these things a little bit. So radial keratotomy, or RK, was a very popular surgery, mostly in the 80s and early 90s. It's now really considered an obsolete procedure with the better procedures we have, like LASIK and PRK, and some of the long-term issues people have. But there are many, many patients who are very happy with their RK. With RK, we're making these, I'll skip ahead here, we're making these radial incisions in the cornea. And by doing that, we're causing flattening for myopic patients. And so again, by making these incisions, you can have more of an effect with more incisions, a smaller optical zone, older patients. There's a study called the PERC study that looked at long-term effects of RK. And 10 years out, about 50% of patients had uncorrected distance vision of 20/20. The biggest problem with RK was refractive stability. And so at least half of patients about 10 years out had progressive hyperopic changes. And these patients also get what we call diurnal fluctuations, where they have changes of their prescription during the day. So typically these patients, from sleeping when their eyelids are closed, these RK incisions would become edematous. And as they became edematous, caused corneal flattening. And so when they woke up, they would be more hyperopic. And then throughout the day, as the swelling went down on those RK incisions, they'd have a progressive myopic shift throughout the day. And so we're seeing a lot of RK patients now who need cataract surgery. And so there are always things that we're considering with RK still, and planning our treatments accordingly. But some things to know about RK: the enhancements are difficult for any refractive error. If you're going to do any laser enhancement, PRK is probably best. But now, nowadays, the age of most patients who have had who have had RK, they're likely more ideal for a lens-based procedure if they're having vision issues. So either doing a refractive lens exchange, which is essentially cataract surgery to fix their focus, or doing a actual cataract surgery for these patients. Many people with RK have issues with glare halos, starbursts, and a lot of issues relating to irregular astigmatism that forms. We always tell our RK patients before any lens-based surgery that there's nothing that's going to give them the quality of vision like a scleral lens or a rigid gas permeable contact lens to smooth out those corneal irregularities and get rid of all of those higher aberrations that they're getting from their irregular astigmatism. Many patients will use scleral contacts. Some don't tolerate them well, but it's always important to have that discussion with them, because there's no surgery we can do to get rid reliably of all those corneal irregularities like a hard contact lens would do for them. So when you do cataract surgery for these patients, there are a lot of different things you need to consider. For most patients, if they have more than 12 cut RK, they'll likely need a scleral tunnel for their surgery if you're doing phaco. Usually, sometimes if you're able to look preoperatively and find an area that looks like you could fit a keratome, you could consider doing a 12 cut without using a scleral tunnel. But the risk that you have is if you ever intersect or put too much pressure on these RK incisions during cataract surgery, you can cause these incisions to rupture open, and then they need to be sutured closed. Typically, you want to avoid multifocal IOLs with these patients. You can consider doing toric lenses if they have regular central corneal astigmatism. Doing calculations for these patients for RLE or cataract surgery is inherently very difficult due to the oblate shape of the cornea and progressive hyperopic shift that they'll have. Most surgeons will use third or fourth generation formulas and aim for -0.5 to -1 spherical equivalent. We know that it takes these patients longer to recover from cataract surgery too, so we usually don't consider the prescription stable until a minimum of 2 months. A couple new technologies that have come out that are really useful in patients who have had RK needing lens surgery are what are called light adjustable lenses that allows us to post-operatively change the prescription of the lens inside the eye, or something called the IC8 lens. This is a picture of an IC8 lens. It works by using a pinhole effect. And this patient is obviously dilated, but when the patient's not dilated, the black ring in there creates a pinhole effect that decreases the aberrations that are getting through the pupil, and therefore decreases the amount of aberrations that patients have, and can be useful if an RK patient has a highly aberrated cornea. So moving on from RK, we'll talk about AK and LRIs, or limbal relaxing incisions. So these we talked about a little bit already, but they have a role in astigmatism management during refractive lens exchange or cataract surgery. We'll do them also for patients having phakic IOLs, or if they need enhancements, even with LASIK or PRK, if they have a spherical equivalent around 0 and just have some astigmatism that they need treated. AKs and LRIs are essentially the same thing. The only real difference is that AKs are more central and tend to be deeper, and therefore, because they're deeper and more central, have more of an effect than LRIs. For these arcuate incisions, again, a coupling ratio of 1.0, which means we're not going to change the spherical equivalent of the prescription. Large transverse AK, so if you just make a straight line incision, those have a coupling ratio greater than 1 and will induce a hyperopic shift. So that's why we usually do arcuate incisions or limbal relaxing incisions that are kind of curved and follow the curvature of the limbus, because they have a coupling ratio closer to 1. Preoperative marking for these patients is important. So you can either mark the patients like this at 0 and 180. The reason we do that is when patients lay flat or lay supine for their surgery, they can have cyclic torsion up to 15 degrees. And so we have these patients sit up. We actually use an instrument that has a level on it to make sure we're hitting that 0 and 180 degree plane whenever we're marking someone, whether it's a toric or for an LRI or AK. There are nomograms you can use. There's an example of a nomogram here that tells you an estimated effect that you will get for each LRI or AK that you're making. So they're very useful. They can help a lot with astigmatism. Usually we'll consider them if the astigmatism is less than a diopter and greater than about half a diopter. Both have good outcomes. There's not tons of literature out there. Sometimes you can induce irregular astigmatism, especially if you're doing these more centrally. So you want to make sure you're at least 3.5 millimeters outside of the optical zone of the eye when you're doing these. So 3.5 millimeters out from the center of the cornea. You can have regression of the effect from these two. And one thing you can do if you do notice that the effect from the LRI or AK wears off is you can actually go in and open the incisions more. That's typically if it's been a femtosecond laser incisions, it's easier to do that. If you've already done the incision manually with a diamond blade or another blade, then you won't have as much success with that. So that's chapter 3. We'll again keep moving along here. So chapter 4, we're talking about photoablation. So big emphasis you'll notice in this book on photoablation. So these are important concepts to understand. Again, excimer laser uses 193 nanometers. That's repeated intentionally, so you get that hammered into your minds that excimer laser uses 193 nanometer wavelength. PRK was developed in the early 1990s. That was the first surgery that really used photoablation. Was surpassed later in popularity by LASIK. With PRK, we remove the epithelium, kind of the steps of the surgery. We remove the epithelium from the eye. There are a lot of techniques that we'll get into on doing that, but remove the epithelium prior to ablation. PRK is still, even though it's been surpassed in its popularity, is still commonly performed and is better for certain indications than LASIK. So you have thinner corneas, if you have patients with dryness, if you have patients with EBMD who've had multiple enhancements or had any flap complications related to LASIK, if you need to do an enhancement, PRK is the way to go. LASIK was developed in the late 1990s. And with LASIK, it's similar in concept to PRK, but instead of removing the epithelium, we make a flap. And so when that was first performed, they used a microkeratome, so a mechanical blade, to create a flap. I've never personally used a microkeratome, but they're still out there and still being used. But the other option is using a femtosecond laser to create that flap. So we'll dive into that a little bit more. Really, we talk mostly about PRK and LASIK, but there are some other procedures using photoablation as well. So one of these other procedures is called LASEC, or laser subepithelial keratomileusis. You can think of this like PRK. So you're still removing the epithelium and then ablating the cornea, but with LASEC, care is made to actually preserve the epithelium. And after you do the ablation, the epithelium is replaced onto the cornea. And the thought with that is that there's potentially quicker healing and less discomfort. A lot of the studies haven't necessarily panned out to show a significant difference between LASIK and PRK, but that's the concept behind it. Epi-LASIK is another form where there's actually a special microkeratome intended just to remove the epithelium. And then the ablation is performed, and then again, the epithelium's typically tried to be replaced back onto the cornea after that ablation. So those are a couple other ones that you may come across. So surgical techniques, it's important every day to make sure that the laser's calibrated. So we always have our staff every single day calibrating the laser and make sure it's functioning properly. The biggest thing to make sure of whenever you're getting ready to perform a surgery is to verify the correct treatment. Again, you can be the best surgeon in the world. You can do a really good screening like we talked about before, but if you enter in the wrong data to the laser, you're going to have very unhappy patients and have a poor outcome. So you always need to verify that you're operating on the correct eye, that your target is correct, whether you're aiming for distance or aiming for a near target, that your sign is right. If we have a couple practices that some of the phoropters are in plus sill, some are in minus sill. So you always need to be careful of that, making sure the power is correct and making sure that you have the correct access if you're treating any astigmatism. After verifying all that, prep the patients. We always like to talk the patients through what we're doing and then place the eyelid speculum. With PRK, we talked about there are many different options for debriding the epithelium. So you can use a sharp blade or a blunt spatula. There are rotary brushes you can do. A lot of people will use 20% ethanol solution to help remove the epithelium. And there's also something called a transepithelial ablation, where you just leave the epithelium intact. We don't have that in the United States, but other places do. And then we talked about LASIK and epi-LASIK. For LASIK flap, most in the US at least are performed with a femtosecond laser. The lasers have excellent depth control. They're very precise, usually have less complications than microkeratomes did, but there are some unique complications, such as something called OBL, which stands for opaque bubble layer, that can form and cause issues with flap creation. This is an example of one type of femtosecond laser used for making flap. So you'll have the laser itself and then some apparatus to dock the laser to the eye, and most of these will create suction to hold the cornea in a steady position. And once the cornea is in position, then the laser will actually make the flap cut, and you can see all these bubbles, these cavitation bubbles we talked about with photo disruption from the femtosecond laser. You can see those being formed. And so that's how the femtosecond laser works at creating flaps. Microkeratomes, again, they're still used. There's some unique risks to microkeratomes. Some of the ones that are more testable that you may hear about are developing a buttonhole where you actually, the cornea kind of bunches up on itself and you can create a hole through the flap. That's more common with steep corneas over 48 diopters. And then there's a risk of free cap where you actually transect the flap and transect the hinge, so there's not a flap, you just have a free floating piece of cornea, and that's more common with flat cornea. So this is a diagram just of how the microteratomes work. Again, there's usually suction and then to try to steady the cornea, and then set at a preset depth, creating that flap. Again, I don't have any personal experience using these, but they are still out there and worked very well. Just the advent of femtosecond laser tended to be more precise and less complications. So this is an example of technique for lifting a flap with LASIK. So many surgeons will mark the cornea with these little black rings you see to help realign the flap once you're laying the flap back. But usually you want to start close to the hinge and free up the space beneath the flap under the hinge. And then a lot of surgeons will, rather than one fell swoop where you try to lift up the flap all at once, a lot of surgeons will work in thirds where they'll work from the hinge side to the inferior side. Most hinges right now are made superiorly, so we'll work inferiorly and do a third at a time, lifting that flap, careful not to puncture the flap as we're lifting it. With PRK, we'll talk about some of the post-ablation steps now with each procedure. So after the ablation is performed with PRK, a lot of surgeons will use mitomycin C 0.02% to reduce corneal haze. Mitomycin C typically applied for somewhere between 12 seconds to 2 minutes. We, as a standard, usually do it for 30 to 45 seconds. And it can vary depending on the amount of treatment. There are a lot of surgeons who don't use it for most cases and have good results. There are some surgeons who only use it for higher treatments. But it is one thing that's been very effective to reduce haze formation that we'll talk about in a little bit here. You can also use sterile chilled BSS on a sponge, drop of steroids and antibiotics. With LASIK, after you lift the flap and do the ablation, the bed is irrigated, proper alignment of the flap is ensured under a microscope, and then typically administer some antibiotics. Post-op, typically with PRK, we use an antibiotic, steroid, and NSAID drop, and have a bandage contact lens that's in place to help with discomfort. LASIK, it's really important to have patients use frequent lubrication. We also use a steroid and antibiotic drop. So outcomes, we consider outcomes for myopic correction with PRK and LASIK essentially equivalent, very good rates of 20/20 or better. Hyperopic correction is less predictable for both. LASIK is superior to PRK with hyperopic corrections. We typically at our practice don't even perform hyperopic PRK, but you can get some studies have reported about 75% 20/20 or better uncorrected distance vision with hyperopic LASIK, depending on the amount. So we'll keep moving along here. I don't know how we're doing for time, Ashiyana.
You know what,
But
Drew, this is so, can I tell everyone how much effort goes into taking a whole book of about 200 pages and giving you, distilling to all of you the like quintessential knowledge. I can't even imagine for Dr. Dickson how much effort this took. So first of all, many thanks to Dr. Dickson. Going, because this is awesome. We are 20 minutes to the close of the session, but I think it deserves that we continue like whatever it takes, because this is their one session in 18 months. They'll have the opportunity to do this. So as whatever it takes, let's do that for sure. And after you, what I'm going to do is I'm going to then go to the refractive roundtable. And then for the answers, I'm going to post it on the group simultaneously and then send everyone a PDF of the answers to make sure that they get that, and in an interest of time, so that we have more time for you, Drew. I think this is
okay. Yeah, I don't want to keep anyone too long, but there's a lot to cover in a lecture. So, and most of the information, this lecture is a little bit front heavy, so we'll keep churning along. Just let me know kind of when to stop, and we can always I'll be sure to send Ashiyana my slides so she has those and can distribute those to you guys as well. So looking
thank you.
Next, thank you. So looking next at some of the complications, adverse events from photoablation, it's important to put this in context of what if they're doing something else, or what's the alternative. So in the United States, at least, the alternative for most people is contact lenses. And it's important to know that patients are much more likely to develop any vision threatening complications related to contact lens wear than they ever are with laser vision correction with PRK or LASIK. So that's something just to create a framework, I think is important to understand. Some of the things that we worry about though with photoablation are overcorrection. So this can result if the stroma becomes dehydrated during surgery. So if you scrape off the epithelium or lift your LASIK flap and take too long to do the ablation, the stroma can dry out and become thinner. And then by doing your ablation, since the stroma is thinner, you're creating more of a refractive effect and can have overcorrection. This is also more common in older patients. can occur with abruptly stopping steroids after surgery. We typically don't consider a refraction stable after surgery till at least 3 months minimum, and can be longer. If you do have an overcorrection and need to retreat this patient, we typically back off the actual recommended treatment amount. So let's say we did myopic LASIK for someone who was a -3 sphere and they ended up +1. We would, if we went to do an enhancement later to treat that +1, we would typically back that off. So we'd probably do either just treating like a half a diopter or 0.75 diopters, because they tend to have more reaction to the treatment. So undercorrection, more common with high levels of refractive error. If you do notice early on that you have an undercorrection, you can consider aggressive steroids early to modulate the wound healing. Dryness is something that is very common temporarily with either of these, more common with LASIK, because you're actually severing the anterior corneal nerves when you're making a LASIK flap. There were some landmark studies called the PROW 1 and 2 studies that showed that most patients actually, after having their LASIK, had improvement of their dryness long-term versus worsening. Many patients will get aberrations related to LASIK or PRK. Very common to notice new glare and halos right away. Optical zone we talked about should always be at least 6 millimeters to minimize the glare and halos. The larger the treatment, typically the more aberrations can be induced. But most patients are typically back to their baseline level before surgery a few months after they have this surgery. CTK, or central toxic keratopathy, something I, again, have never seen, but dread seeing. So this is a rare acute non-inflammatory central corneal opacification that you can develop within days of surgery. It's often a very acute onset and doesn't progress. We don't know why this happens, but it causes a hyperopic shift in the prescription and typically resolves after several months without intervention. So often this is mistaken early on as a different type of complication, something called DLK, or maybe an infectious keratitis or something like that. And so typically you'll see this pattern where you get this central opacification and edema there, and you can see some folds in the cornea, but that can significantly lessen the visual acuity. The good news with this is that most of the time it does get better on its own just with doing nothing, but it can take several months for that to happen. So patients are usually pretty unhappy to see that. Infectious keratitis, very rare, but it can happen. It's more common in PRK since we're inducing an epithelial defect and you don't have that epithelial barrier to help protect from infection. Most of the time, this is going to be related to gram-positive organisms just from the eyelid flora. So typically treated just with broad spectrum antibiotics. Most of the time, if caught early, is very treatable without having significant visual effect. Some unique complications we think about with surface ablation are persistent epithelial defects. Most of the time, the epithelium is has rehealed and regrown within 5 to 7 days after PRK. But some people will have issues with wound healing if they have underlying medical conditions like diabetes or autoimmune disease. They can have a harder time re-epithelializing and can have persistent defects that can be hard to treat. Haze is probably the most dreaded complication of PRK. So haze is caused by keratocytes in the cornea that basically react abnormally and have abnormal wound healing without that lamellar look of the cornea. There's a bunch of irregular collagen fibrils that are created and cause this hazy cornea. We know that higher treatment is a risk factor, UV exposure. You can decrease that risk with using mitomycin C. Usually it will start to appear a few weeks after surgery, peak 1 to 2 months later, and then improve over 6 to 12 months. Treatment can include steroids, both topical and oral. You can do SK, you can do PTK to try to help with this. This is kind of the appearance of haze. So it's not typically hard to identify. It's not subtle, but usually you will see this improve on its own after several months, but may not go away permanently and can cause some permanent scarring. Unique complications of LASIK, we talked about buttonholes and free caps with a microkeratome. There's a picture of a buttonhole. You can see just that little hole that was created by the microkeratome flap. Flap striae, this occurs from flap misalignment when you're replacing the flap after ablation. There are microstriae, which are very fine hair-like, not often visually significant, or there are macrostriae, which are full thickness flap and kind of cause these undulating folds. If these are visually significant, you can relift the flap. It's often best to do this right when they're detected. Usually you will see them within 24 hours of surgery. So that's one of the main reasons we bring people back a day after their LASIK, is to check for flap misalignment and striae. And if we need to, you can relift the flap and smooth it out and lay it back down. And this becomes much more difficult over time as the flap edges reepithelialize, and you can get the flap will kind of scar down and become more permanent and harder to treat. DLK, or diffuse lamellar keratitis, is a relatively common thing. After LASIK, it's reported about 1 in 200 or 250 cases. So if you're performing a lot of LASIK, you will see this at some point. This happens as a result of sterile inflammation that can occur to a variety of insults. There can be endotoxin from sterilizers not being maintained properly is one of the main causes. But if you get a lot of meibum in the flap interface, or blood, or any particles from Weck cells or other things that you're using during the cases, that can induce DLK. It forms what we call a sands of Sahara appearance. It's important in distinguishing this from other post-LASIK types of inflammatory appearance, that the inflammation occurs within the flap edge. So this doesn't occur outside of the flap. So on your differential, that's something important to look at, that if it's maintained within the flap edge, it could be DLK. If it's outside of the flap edge, you might want to think of something else. This is graded from stage 1 to 4 based on severity. The more mild stages typically respond to topical steroids or oral steroids. If it's a stage 3 or 4, you may need to lift the flap and irrigate out some of the inflammatory cells. These are some pictures of picture A is what we call stage 2 DLK. B looks like stage 3 DLK, where you get more concentrated infiltrates there, and would require needing a flap lift most of the time to get rid of that. We talk about infectious keratitis with both of these. There's also LASIK infectious keratitis, which post-LASIK gram-positive organisms are still the most likely cause. But one thing that's kind of a buzzword related to this would be atypical mycobacterium causing these. So that's something to think of if you have a post-LASIK infectious keratitis. There's another thing important to know about called PISC, or pressure-induced stromal keratopathy, that looks similar to DLK, but it's actually caused by increased IOP in the eye after LASIK that can push fluid into the flap interface. And often isn't detected because as there's fluid in the flap interface, if you're checking a pressure, it can be normal. So you want to either use like a tonopen peripherally, or there's something called dynamic contour tonometry that can be used to look at this. But if you think you're treating DLK and throwing steroids at this eye and it's just not getting better after a week or two, then think PISC, and actually cessation of steroid drops and starting on IOP lowering drops is the proper treatment. One last complication we'll talk about with LASIK is epithelial ingrowth, where you can have, as the flap edge is healing, you can have epithelium actually start to grow under the flap. And most of the time with this, people are asymptomatic because it typically stays peripheral. If it becomes more central and more visually significant, you can either use a YAG laser actually to remove that epithelium very carefully, or you can lift the flap and scrape that out. More common if you have an abrasion or multiple retreatments with LASIK. This is kind of what that looks like. And so it's pretty identifiable, but that's something that's not uncommon as well. So that's it for all the photo ablation stuff. We'll move into chapter 6 here. The chapters start getting a little shorter here, so we'll pick up the pace a little bit. But SMILE is something that's important to know about. It's a type of femtosecond lenticule extraction. Was initially approved in Europe in 2009, in the United States in 2016. there were two procedures that kind of preceded it called Relax and Flex. But essentially what happens with SMILE is that a femtosecond laser creates this lenticule using photodisruption, kind of carves out this lenticule in the cornea of the patient's prescription. And then we're able to remove that lenticule without needing to create a flap or do an ablation. And so in the United States right now, it's only approved for myopia and myopic astigmatism. There are other places where it's being investigated more for hyperopia, similar contraindications to LASIK and PRK. Currently, the Zeiss VisuMax femtosecond laser is the only technology that has the capability to do this, but a lot of the other big companies are looking at creating their own lasers that have this capability. Some of the advantages to SMILE compared to other laser vision correction would be that it only requires a femtosecond, so you don't need a femtosecond laser and an excimer laser to do this. There's less transient dryness than LASIK because you're not making a circumferential flap and severing all those corneal nerves. With LASIK, you're only making, or with SMILE, you're just making a small incision, and varies where you're at. In the United States, we have to use about a 4 millimeter incision. Other places they can use smaller ones, but that's one advantage. There's thought that because you're preserving more of that anterior stroma and not making a flap through it, that there's potentially more biomechanical advantage and less risk for ectasia. But that's something that's still kind of up for debate. Some disadvantages of SMILE. Typically has a little bit longer visual recovery than LASIK. So instead of being like next day seeing really, really well, it can be sometimes a few days. I would say most people, and it's center dependent and surgeon dependent, but most people are probably more like that 20, 30-ish range the next day after SMILE, which is still very good, but LASIK, often people are right around 20/20 the next day. So currently in the United States, there's a smaller treatment range allowed than for LASIK. Again, you can't do hyperopic treatments or mixed astigmatism. SMILE does tend to be more difficult to enhance. So if you are off by a little bit, if you have an overcorrection or undercorrection, it can be more difficult to go back and do something. So the technique most commonly used if you need an enhancement after SMILE is PRK. We've started doing a lot of thin flap LASIK over the SMILE bed. And so we'll do a thinner flap, usually like a 90 micron flap, and have a nasal hinge and do that. That's another good way to do it. But most of the literature out there supports that SMILE enhancements occur less often than PRK or LASIK. So it's rare to need to do an enhancement, but those are more difficult with SMILE than LASIK or PRK. With SMILE, this is how the femtosecond laser makes these cuts. So it does these cuts in different stages. The first side is what we would call the lenticule cut. So this is the posterior edge of that lenticule. And this is the refractive cut. So this is where it's actually curved depending on the patient's prescription and shaped to their correction. Then it will make side cuts on that lenticule. And then what we call the cap cut, which is the anterior cut of the lenticule. Usually in the United States, we leave this cap at about 120 micron thickness. And then the final step is this cap incision where you can actually extract the lenticule. This is a picture of the technique to remove a SMILE lenticule. It is certainly more technically challenging than performing PRK or LASIK, so there's a steeper learning curve. Complications are usually most common for people learning how to do SMILE than experienced surgeons, just because it is a steeper learning curve. And I'll let you guys look over that if you're interested without going into the technique too much for that. Outcomes with SMILE are equivalent to LASIK and PRK, slightly longer recovery than LASIK, like we talked about. Again, most complications intraoperatively are related to surgeon inexperience. You can have cap tears as you're removing that, where you actually tear the cap. You can have pieces of the lenticule that become retained. Some lenticules, if the laser doesn't do a clean cut, can be difficult to extract. Post-operative, you can still have some dryness with this, less than LASIK. You can develop some haze in the interface that typically goes away. You can develop inflammation. You can actually get DLK with SMILE. I've seen it a time or two, but typically less often than LASIK. And then we talked about enhancements with SMILE a little bit. So that's SMILE. We'll talk next about refractive surgery and ocular and systemic diseases. So ocular surface disease is probably the most common thing that we come across and very important, especially when you're talking about doing laser vision correction on the cornea to screen for. We talked about this a little going over chapter 2, but thorough history and slit lamp exam are important. You can consider some actual extra testing for measuring dryness. You, of course, want to be looking for blepharitis and meibomian gland disease and punctate epithelial erosions and tear breakup time and all that on your slit lamp exam. But you can also consider some testing for tear osmolarity, MMP9, meibography, where you're actually visualizing the meibomian glands, and some other tests. Topography, tomography, and epimapping are also very useful when evaluating the ocular surface. Treatment for this pre-op and post-op. So if we have someone come in who's looking to have refractive surgery and we notice a lot of ocular surface disease, we treat that before their surgery and try to get that looking better. If they develop this post-operatively, we also treat that, and that's one of the main things we're looking for in their post-op visits, especially with LASIK. But you can use a variety of treatment modalities. You can use artificial tears, anti-inflammatory drops like cyclosporin, punctal occlusion. We use a lot of serum tears where patients will actually get a blood draw, spin out the red blood cells, and then dilute down their serum and turn that into a drop they can use. It works very, very well for people with more severe dry eye. Most patients after surgery, again, return to kind of their baseline level of dryness within 3 to 6 months. Screening for herpes simplex and herpes zoster are very important. There are cases that are reported both post-PRK and post-LASIK. Having had this is not necessarily considered an absolute contraindication, but is a relative one. It may be best, if possible, to avoid using an excimer laser because it's thought that that UV light frequency, that 193, can reactivate the herpes virus. So if patients are candidates for something where you're not using that, like ICL is probably the best because you're avoiding significantly changing the cornea altogether, but SMILE may be safer. You can consider using prophylactic or treatment dosing perioperatively if you're performing this on a patient with a history of herpes, but you certainly need to have this discussion with patients and make sure that they understand the risks that are involved. Keratoconus, probably the most important thing to screen for aside from dry eye issues prior to laser vision correction. Keratoconus itself is considered a contraindication to laser vision correction. So if you see someone with frank keratoconus, they should not have surgery on their corneas. Some people will consider doing something like PRK on patients who have keratoconus if they've had cross-linking and the cornea appears stable. Not everyone does that. There's mixed camps on that, but you may come across people who will consider doing that. It's very careful in your pre-op exam to pay attention to the topography, tomography, and pachymetry to look for form fruste keratoconus, which I know we had a question on that earlier, but form fruste keratoconus is basically findings on topography, tomography that are suspicious for keratoconus without meeting the criteria for keratoconus. So you want to look at those patients because they might be kind of on the pathway to becoming frank keratoconus, but not quite there. So those patients are really important to screen for. Things that you need to look for are irregular astigmatism, skewed radial axes, inferior steepening or asymmetric steepening. You can actually have keratoconus. There's a subtype with superior steepening, and also looking for posterior elevation on your tomography. Epithelial mapping, as we looked at, is very helpful. There's also people who do corneal biomechanics to look at corneal hysteresis. And then there's some people out there who will do genetic testing, which hasn't, there's not one specific gene that we test for keratoconus, but there are a number of genes that have been implicated or related to keratoconus that there are companies that will do screening for that, but a variety of methods to detect that, but very important to make sure your patients don't have keratoconus. Corneal dystrophies, we won't go through all of these, but some of the more common ones we'll come across are EBMD. Those patients are better off to have PRK, which can actually be therapeutic for their EBMD, but you want to avoid, if you know a patient has EBMD, you want to avoid LASIK because you can have issues with epithelial healing. You can get something called vertical gas breakthrough where the entire epithelium can essentially come off in one clean sheet with LASIK as you're making a flap with a femtosecond. So PRK is a better option for those patients. Fuchs dystrophy, there are some people who, if patients have very, very mild Fuchs, will perform LASIK or PRK. Most patients who have Fuchs, people won't operate on, but there are some out there who do. So not necessarily a total contraindication, but a relative one, but proceed with those patients with caution. There's thought that with LASIK, Fuchs dystrophy patients will have a harder time maintaining their flaps, because the initial mechanism to maintain the flap is actually the endothelial pump. And so if you have less endothelial cells doing their job, that negative pressure gradient from the pump can't hold the flap in place, and you can have issues. In other corneal dystrophies, it's, as a general rule, laser vision correction is probably not for you if you have some of the other corneal dystrophies. After PKP, you can consider doing refractive surgery, not done often, but you need to make sure it's healed and all the sutures are removed. Scleral lenses and gas perm lenses will offer the best quality after PKP if patients are having issues. For people with ocular hypertension or glaucoma, it is okay to perform surgery in patients who have ocular hypertension if the patients are counseled on risk of developing glaucoma in the future. Typically, if patients have glaucoma, they're not candidates for refractive surgery. You could consider it if they were mild. PRK is better. LASIK, when you're forming the flap and having that suction to the cornea, the IOP is elevated, and there are reports of causing visual field defects in patients with glaucoma just with flap creation. The other thing to know is after you make a flap especially, but even thin corneas with refractive surgery, you may be getting falsely decreased IOP readings on patients. So if you have a patient who has had LASIK or PRK or something and has glaucoma, you need to be carefully evaluating their pressure, because it's likely falsely decreased from the thinner cornea. Prior retinal detachment patients may have refractive surgery if things are stable. You need to make sure that they don't have conjunctival scarring to affect LASIK flap formation and suction. So if you are thinking about doing this, PRK is best. There's no evidence of LASIK or PRK increasing the risk for retinal detachment, but often these patients are myopes and inherently at more risk because of that for retinal detachment. So at our practice, typically if a patient has myopia greater than a -6 or an axial length greater than about 26, we'll send them to a retinal specialist just to be screened and make sure they don't have any pre-existing pathology that can be treated prior to surgery. Patients with amblyopia, you can consider refractive surgery as long as these patients have reasonable expectation, no significant strabismus, and a reasonable correctable distance vision acuity. So, we'll often see amblyopic patients who their good eye, they see 20/20, and their amblyopic eye, they can see to 20/40, but at baseline, they're 2200. As long as they're not ruled out of surgery for other reasons and have reasonable expectations that, we're not going to make this amblyopic eye better than 20/40, it's reasonable to do that. In that case, refractive surgery can actually help in accommodative ET by treating the hyperopia. It decreases that accommodative drive and can help. For a lot of patients who have amblyopia or have had prior strabismus, doing a contact lens trial where you put the prescription you're treating in as contact lenses and letting them try that can be helpful to make sure you're not inducing any new deviations in their alignment, because there are certainly reports of that after refractive surgery, so you need to be careful. Patients with HIV, you can consider doing refractive surgery if the viral load is undetectable and normal CD4 count. You don't want to perform if the patient is significantly immunocompromised. There's concern of doing ablations that you might actually aerosolize the virus. And that hasn't really been substantiated, but there is that concern there. So that's something to think about. Patients with diabetes, you can perform refractive surgery if it's well controlled. They may have abnormal wound healing or take longer to heal. So that's a discussion to have with them. Same thing with autoimmune disease. If they have active rheumatoid arthritis or something like that, you don't want to perform refractive surgery. But if everything has been stable and they haven't had flares for years, it's reasonable to consider that as long as they're counseled appropriately. So next is considerations after refractive surgery. We'll talk a little bit about IOL surgery. And so this is a very difficult thing to calculate after refractive surgery for a couple reasons. One is that after refractive surgery, most patients will have smaller effectical optical zones. The other big reason is there's an altered relationship of anterior to posterior corneal curvature. So on biometry measurements, when you're measuring the Ks to calculate what lens is best, these measurements are altered from refractive surgery. So if you've had a myopic correction, the Ks are often overestimated by the biometer, which can result in hyperopic outcomes after cataract surgery. And the reverse is true for post-hyperopic. Those Ks are often underestimated, resulting in myopic outcomes. So very difficult to choose those. There are some things that can help in the accuracy of the IOL calculations. Some people will use what's called intraoperative aberrometry, where after you remove the cataract, you bring in a intraoperative aberrometer that will give you measurements used for IOL calculation, can be helpful. At our practice, for most patients who have had refractive surgery and need cataract surgery or need a refractive lens exchange, we'll use a light adjustable lens, which is a lens we'll talk about in a little bit more, but you can actually change the prescription of the lens after surgery. So if you have a refractive surprise or a poor outcome, you can actually adjust the prescription after surgery, which is a really great option to have available. There are different methods that the book talks about post-refractive IOL calculation. I won't get into those too much, but most people will use the ASCRS online post-refractive calculator, where you can plug in if they've had prior myopic surgery or hyperopic surgery or RK, and it helps in the calculations, makes those more accurate. And I included the link there for you guys to use as a reference if you're ever in that situation doing surgery on a post-refractive patient. Patients who have had prior retinal detachment surgery, or if they need retinal detachment surgery after LASIK, they can often have flap issues, especially if they need to debride the epithelium during a vitrectomy. So that's something to be aware about. Corneal transplant, you just need to be careful if they've had RK or LASIK about your trephination, because you can intersect the RK incisions and cause issues. And oftentimes with LASIK, the flap size is bigger than the tree fine. So you can have flap fragments that can be there. So you need to be careful about that. That's chapter 8. So chapter 9 here, we'll talk a little bit about intraocular. We've mostly been focusing on this corneal based and refractive surgery. Now we'll focus on intraocular. So phakic IOLs are something that have become increasingly popular recently. These were first invented in the 1950s, gained popularity in the 90s. They come in two main varieties. So they're either iris supported with a Versace or artisan lens, or sulcus supported with the implantable Collamer lens, which is what is most commonly used nowadays. The iris fixated required large incisions. These were made out of PMMA. So usually you'd have to make at least a 6 millimeter corneal incision, which would induce astigmatism and could cause some issues. And these had higher complication rates. There's also historically something known as a angle supported phakic IOL, where the lens would rest in the angle, and you can imagine that caused a lot of problems, resting in the angle with pressure issues and iritis and things. And so those are not commonly used anymore. Some advantages of phakic IOLs are that they offer higher treatment ranges than laser vision correction. So the ICL, or the implantable Collamer lens, is indicated for people in the United States with myopia from -3 to -20. So if you have a very high myope, you can safely treat that myopia at higher ranges than you can with LASIK or other laser vision correction. It's reversible or replaceable. These ICLs are very flexible. They're made out of a synthetic material that is a mix of a polymer and collagen, and very flexible, easy to remove or replace if you ever needed to. Most of the time when we put in an ICL, it stays there until patients need cataract surgery several decades later. And it doesn't affect outcomes, or it doesn't affect biometry readings or lens calculations when that ICL is in there. These are also better for people who have dryness or any corneal irregularities that you're concerned about. So if you see someone with form-fruit keratoconus and are worried about inducing problems, ICLs are often a very good option for those patients, because you're not creating increased risk for ectasia by ablating tissue. Some disadvantages: the old versions of ICLs, you needed to do a peripheral iridotomy because you could get pupillary block. So you needed to create an alternative pathway for the aqueous to flow through behind the iris. With the current model that's approved in the United States and has been approved in other countries for longer, it's called the EVO ICL, but it has a central port that allows aqueous to naturally flow through without needing to create a peripheral iridotomy. Other disadvantages: you are doing intraocular surgery, so there's a higher risk for endophthalmitis, but typically very low risk of endophthalmitis because you're leaving the capsule intact, and typically less complications related to that. Historically, there was an increased risk of cataract formation and pupillary block with the older versions of ICL. Nowadays, that risk is essentially zero with the EVO. The thought is that with the central port on the EVO lens, you're bathing the anterior lens capsule in aqueous like it normally would be, and therefore have less risk of cataract formation. So indications for these, like I talked about, myopia -3 to -20 will treat up to 4 diopters of astigmatism with a toric version of ICL. Other countries, they have hyperopic ICLs available that can treat up to 12 diopters of hyperopia. Typically, these are contraindicated in people who have an ACD less than 3 millimeters. Many surgeons actually go lower than this. We typically go down to about a 2.8 or 2.7 in certain cases if patients have very healthy endothelium. You don't want to do this if someone has endothelial disease like Fuchs or glaucoma, cataract, uveitis. Sizing is very important. So they typically come in 4 main sizes of ICL. You can base the sizing off of the white to white measurement on the patient or with ultrasound. We typically do a combination of both, but some studies have indicated that ultrasound is the most accurate, measuring the actual sulcus length of where this ICL sits. So these are just some pictures from the text of phakic IOLs. The top image there is of an iris fixated one that you can see sitting in front of the iris. The bottom two are of an ICL, and you can see the ICL before its insertion in that second image, and then see a Scheimpflug image of where that ICL sits. So it's sitting right behind the iris, right in front of the natural lens and the sulcus. And this is what it looks like intraoperatively putting those in. So outcomes with phakic IOLs are excellent. Many really high myopes can actually gain lines of corrected distance vision acuity because you have less minification effect of your images compared to people needing to wear, like a -15 glasses or something. Glare and halos are pretty common early, typically improve over time. So that's phakic IOLs. Refractive lens exchange we talked about a little bit. That's essentially doing cataract surgery, but the purpose is to fix focus. Typically, we don't consider this in patients until they're around age 55 at our practice. Others do it at different ages. We'll consider it in earlier patients if they're high hyperopes or things like that. But with one surgery, with the lens technologies that are available now, you can fix people's distance vision, fix their near vision, fix their astigmatism, and prevent cataracts from ever developing just in one surgery. So it's pretty remarkable. This option has grown in popularity with improvement in surgical technology and techniques. Many of these patients coming for this type of surgery have very high expectations, so counseling is important. Once again, that's the common theme throughout this, is you really need to counsel. You also need the ability to perform an enhancement. We tell our patients that 10 to 15% of the time, we're going to be off the mark with the prescription of the lens we put in their eye, and they'll need to have something like LASIK or PRK to do a subtle enhancement to achieve the best vision possible out of contacts and glasses. So you need to have a means to be able to fine tune the prescription if you're off a little bit. Pre-op workup is very similar to cataract surgery. There's special importance placed on making sure they have very normal, healthy looking eyes. IOL options, there are several out there, depends on patients' goals. Often you will use some type of an extended depth of focus lens that gives good distance and intermediate vision, or a multifocal or trifocal lens to give them a more full range of vision with distance, intermediate, and near. We use a lot of toric lenses and LRIs and things to address astigmatism. We also will do light adjustable lens set up with blended vision to really fine tune the prescription. And we tell patients that it kind of lets them test drive their vision because they can see where their prescription is at and give us feedback. And then we can adjust the lenses accordingly to give them more near, less near, and really fine tune it. So those are some good options. Technique is very similar to cataract surgery. Some important modifications you need to think about, though, are that these lenses of the patients, because they're typically younger, they're softer, they're thinner. So you need to pay special attention to the posterior capsule and make sure you're not causing any problems with that. Typically, it's a little bit harder to hydrodissect and rotate the lenses. Centering the IOLs is very important. These multifocal trifocals you want to have lined up in the visual axis. Minimizing phaco energy, if you're using phaco, is important to improve the recovery. And often surgeons, at our practice, we do same day bilateral surgery for these patients. Some people do that, some people don't, but that's becoming more and more popular. Complications very similar to cataract surgery. And we'll talk about the light adjustable lens a little bit in more detail here. So the light adjustable lens, it's the only technology currently available that allows us to change the prescription of the lens after surgery. So it's really cool. So if you're off at all on your measurements and have a refractive surprise, you can fine tune the focus. So typically you can treat a couple diopters of sphere and a couple diopters of cylinder. We usually wait a minimum of a month to do these treatments, but we have a machine that you input the patient's prescription and then what you want their prescription to be. And then the machine uses a proprietary algorithm to shine UV light on the lens to change it in a specific pattern to change the focus. So it's a very, very cool technology and a great option for people. There's a term called bioptics that is used in refractive surgery that is planned vision correction using a combination of intraocular surgery and laser vision correction. So for example, if you have an ICL and a really high myope, there was a patient I did a couple of weeks ago that was a -18 who needed or wanted surgery, and they only make the ICLs up to a -16. And so she's going to be left with some residual refractive error. You can plan to do a combined surgery at a later date where you would do an ICL and then something like LASIK to take care of that residual refractive error. So final chapter here, talking about accommodative and non-accommodative treatments of presbyopia. There are some scleral surgery options for accommodation treatments in presbyopia, not commonly performed anymore. These are basically aimed at weakening the sclera overlying the ciliary body that allow zonular tension to increase the accommodative amplitude. Largely abandoned. There are some studies ongoing right now where they're actually looking at making micro perforations in the cornea using a YAG laser overlying, or in the cornea, in the sclera overlying the ciliary body to weaken that to help with accommodation. There are some accommodating IOLs. There's only one available in the United States, but multiple others under investigation. Several non-accommodative treatments for presbyopia. So blended vision, we talked a little bit about. You can perform this with laser vision corrections, ICLs, or IOLs. There are limits to how much anisometropia you want to create. So typically the maximum that we like to do routinely is a -150 for the near eye. Some can tolerate more, but the more you do, the more issues you have with stereopsis and acceptance of the blended vision. With blended vision, we typically take a dominant eye and aim it for best distance, and the non-dominant eye, we aim for more near vision. You can flip that. I know people who have who work on computers all day and or are lawyers or things that are constantly reading and signing documents and things, who want their near eye to be their dominant eye. So you can do that. Most of the time it's done with the dominant eye for distance. Blended vision can decrease your contrast sensitivity and stereopsis. So that's important to discuss with patients ahead of time, but it's a very successful option for people to decrease their dependence on reading glasses. I'm not sure why there's this red line here. I just noticed that. But
I think
anyway.
I think one of the participants must be making notes.
Oh, I didn't. Yeah, no, that's okay. That's all right. Feel free to edit. Maybe it needed a red line, a little pop of color in there or something. But CK is something you'll hear about, not commonly performed anymore. I remember when I was a resident on some of my testing that I had on some of the standardized tests. I remember there was one where I had 3 questions on CK. So it's something that's kind of stuck with me. But conductive keratoplasty is a technique to help induce 1 to 2 diopters or so of more myopia. So with this technique, you use a radio frequency probe to treat the peripheral cornea that causes flattening of the peripheral cornea or shrinkage and subsequent central steepening of the cornea. So this is a nice diagram to kind of show. So you put these little spots in the peripheral cornea to cause the central cornea to steepen, and typically it's done in the non-dominant eye of patients to give them some increased near vision, and worked pretty well, but had a regression of effect, and so is not commonly performed anymore. Other options for presbyopia, we talked some about multifocal, trifocal, EDOF IOLs. Nowadays, most of this technology is used with what we call diffractive technology. So these types of lenses, diffractive technology, they have these concentric rings that will create a gradient that utilizes constructive interference of the light propagating through the lens to create multiple focal points. So if you're using a multifocal lens, that's often just a couple focal points where you'll have a distance and a near add. Some of the more common near adds are like a 2.75 or a 3.25. Or you can use a trifocal lens where you create distance, intermediate, and near focal points. So there's another term called apodization that is a tapering effect between these diffraction gradients that lessen the height and yield even more even distribution of light to cause a smoother transition for patients. So those are commonly used lenses for presbyopia. This was a table from your book going into a lot of the lenses. We won't go into all of these, but just know there are a lot of options out there for improving people's near vision. With these lenses, again, patient selection is important. They need to have realistic expectations. You need to explain that with these lenses, there's increased glare and halos. Most people will notice glare and halos with these types of lenses. Less than 5 to 10% of people are significantly bothered by them. You also need to make sure the eye itself is very healthy and there's absence of significant pathology. Careful surgical technique is important. Again, these patients typically have higher expectations, so you need to make sure you're doing a good job in centering the lens well, and if it's a toric, lining it up well, things like that. We always like to explain to people the concept of a YAG capsulotomy, and that often these lenses, because they're so sensitive to ideal conditions in the eye, they need early YAG capsulotomies. And so most people that we will use multifocal or trifocal IOLs on will need a YAG within the first year or two. And also these patients, 10 to 15% of them will need an enhancement if they have a little bit of astigmatism left over, or myopia, hyperopia, et cetera. You can treat that. There's been a lot of research out there that patients, especially with multifocal lenses, are sensitive to even half a diopter of astigmatism. So you have to be, if you have patients that are complaining about their vision quality not being good and they have that, we're pretty quick to treat that with an enhancement. There is a concept of something called multifocal corneal ablations, where instead of having a multifocal IOL within the eye, you're kind of creating a multifocal lens in the cornea. This isn't performed commonly in the United States. There are variations in other countries that are under investigation. There's something called Presbeyond, which is popular in Europe, which is a technique utilizing a small amount of blended vision and spherical aberration within the corneas to improve range of vision. There are corneal inlays. Historically, there's something called epikeratophobia, where they'd actually take a donor lenticule of corneal tissue and lathe it into the proper prescription and then suture that onto the cornea. That's not performed very often anymore. There are other inlays that are being looked at in other countries used for hyperopia and presbyopia. There's a company called Alatex that takes human cornea tissue and can request whatever prescription of that you want, and then insert under a LASIK flap to give increased reading power. And so that's something that is coming down the pipeline. There are things called alloplastic inlays. So some of the main two that you may hear about are the camera and raindrop inlays, which were pretty popular just a few years ago. They've fallen out of favor. The raindrop was actually recalled by the FDA because it induced corneal haze, but it was basically a central ad that you would put under a LASIK flap. The camera inlay was a pinhole, kind of like that IC8 lens that you saw earlier, but you'd actually put it under a LASIK flap and it'd create a pinhole effect to elongate the depth of focus and give patients more reading power. There are some others under investigation now. Lastly here, there are presbyopia drops. So there's one called Vuity that was just approved by the FDA in the United States. It's a 1.25% pilocarpine. So obviously not a super novel medication because we've been using pilocarpine in ophthalmology for over 100 years, but through pupil constriction can create an extended depth of focus and help with near vision. The main mechanisms of those are to either induce miosis, or there's actually some drops under investigation that will reduce disulfide bonds in the lens to allow the natural lens to accommodate more. And then there are several emerging lens technologies. There are some that are filled with fluid, IOLs that you insert in the eye that can accommodate, as there's that accommodative reflex and give some near ad. There's some electric stimulated IOLs that can be stimulated to kind of have this pseudo accommodation effect. And then there are some that have replaceable optics that you can swap out and put more reading ad and things in. So there's all sorts of stuff under investigation. Everybody ends up being presbyopic at some point. So it's a hot area of research. So that is finally the conclusion of everything. Thank you guys so much for bearing with me. I know that is a ton of information to go over in a short amount of time, and I know we ran over, so thanks for being patient. But hopefully that was a useful summary to you. You guys should be able to have my slides to reference. Make sure you read the book chapter. If not, there's more and more emphasis being put on refractive surgery. I know Ashiyana is working on helping to build some other refractive surgery centers around the world. And, as we talked about earlier, refractive surgery is not just some expensive luxury. It's a lifestyle enhancement. It's functionally better for places where there's not access to contacts and glasses. It offers a more permanent solution to correcting refractive error. And as we know, refractive error is the most common cause of needless blindness worldwide. So there's a big need for that, and hopefully you guys can get some exposure and things to that at some point. But thank you very much for your attention. I'll turn things back over to Ashiyana now.
Dr. Dickson, thank you so much for such an enlightening, if you will, if that's the right word, enlightening session. It jam-packed for sure. And for those who do not have access to refractive lasers, it may look to you like it is, a shot in the dark. But Dr. Dickson has gone through highlights of all chapters of this book for you. So it is an opportunity for you to now go back. You will also get the PowerPoint, as Dr. Dickson said, of his slides. And now I would suggest you go back to your reading again to solidify that knowledge, to really make sure that if you're not sure of what certain things mean, first of all, they're not stupid questions, because this is a tough area. Refractive surgery is not easy, right? There's 2-year fellowships out there in order to achieve the knowledge that we have presented to you today. So by repetition and the reading over and over and over again and asking questions to Dr. Dickson and myself and any of the refractive surgeons that are available to you, you will win.